Over the next 90 minutes, live from Children's Hospital Boston, watch an interactive expert panel discussion of vascular anomalies. Vascular anomalies, which include vascular tumors and malformations, are commonly misdiagnosed, resulting in inadequate or inappropriate treatment. To ensure the best outcome, patients with vascular anomalies require the combined expertise of an experienced interdisciplinary team of specialists. In just moments, the VAC team will evaluate cases, provide diagnoses and treatment recommendations, and answer questions emailed to them from physicians and families live. OR Live makes it easy for you to learn more. Just click on the Request Information button on your webcast screen and open the door to informed pediatric medical care. Now, let's join the doctors.
Welcome, good evening. I'm Dr. Stephen Fishman, one of the co-directors of the Children's Hospital Boston Vascular Anomalies Center, and we welcome you to our weekly conference where we review patients from around the world with sometimes simple and sometimes complex vascular anomalies. I'm going to go ahead and introduce many of our panel members here. We have a multidisciplinary group. On my left, Dr. John Mulliken, co-director of the Vascular Anomalies Center, founder of the Vascular Anomalies Center, and a plastic surgeon. To Dr. Mulliken's left, Dr. Judah Folkman, scientific director of the Vascular Anomalies Center, and a pediatric surgeon, and also the founder of the entire field of angiogenesis and angiogenesis inhibition. Next, Dr. James Kasser, our chief of orthopedic surgery. Dr. Darren Orbach, a neurointerventional radiologist. Dr. Edward Smith, a neurosurgeon. Dr. Yanula Clement, an oncologist with us here at Children's Hospital as well as the Dana-Farber Cancer Center. On my right, Dr. Harry Padua, interventional radiologist. Dr. Ahmad Alamari, interventional radiologist. To Dr. Alamari's right is Mary Beth Sylvia, one of our vascular anomalies nurse practitioners. Unfortunately, Erin Ryan, her colleague as a nurse practitioner, isn't able to be here today due to a family emergency. Next to Mary Beth is Dr. Victor Fox of gastroenterology, Dr. Harry Kazakewicz of pathology. To the back row, to my left, Susan Connors with vascular anomalies and vascular biology research. Dr. Qian Liu, a researcher in vascular anomalies. Dr. Harriet Paltiel, a radiologist with particular expertise in MRI and ultrasound. Jessica Lissy, our social worker. And Kim Shalash, our vascular anomalies administrative assistant. As you can see, we have a very diverse group of specialists who focus on vascular anomalies. All of us have our own practices in our various specialties with a focus on vascular anomalies. The people who really lead the show are those who do full-time vascular anomalies, and that are Kim and Jessica and Erin and Mary Beth. Now I'm going to ask Dr. Mulliken to talk a little bit about the history of vascular anomalies and about our center.
Vascular anomalies is a large field involving lesions that where there are abnormal blood vessels and lymph vessels. So it involves arteries, veins, capillaries. We divide vascular anomalies into two large groups: tumors, lesions which grow because of increased cell turnover, and malformations, where there's an abnormality in the shape and the size and the flow in these various channels. As I say, it's a large field. We didn't realize that until several years ago. There are both lesions that are common and lesions that are rare. Now we know this field involves most specialties, both medical and surgical. In the past, the patients used to wander from doctor to doctor because there was no one doctor that could take care of the problem. And fortunately, over the last 10 years, even 15 years, vascular anomaly centers have grown up, so these patients no longer have to be medical nomads looking around for someone that knows what to do with them. Our center began in the mid-'70s when I was working in the plastic surgical clinic, and I saw a lot of these red, purple, and blue things on kids' faces and in their skin, and I really couldn't understand what they were because the books had all the wrong names. So we took the kids out of that clinic and we started our own clinic for vascular lesions, we call them. And I was joined by a radiologist over the next 10 years, 15 years. Toward the end of the 1980s, There was a lot of excitement, as there is today, about drugs that inhibit blood vessels, and I called on my former chief resident, still my chief, Dr. Judah Folkman, to join me, and we started having conferences along with Pat Burrows and others in the early 1990s. And ever since then, the Vascular Anomalies Center has grown to the size that you see today.
Well, we're going to go ahead and proceed with our conference. Now, we have a few activities that we do here at the Vascular Anomalies Center. We see patients together in a group clinic on Fridays. We see patients individually in our offices. We provide services of all types, whether it be medical, surgical, or in the interventional radiology suites. And one of the things that we do every week is have this conference. We provide this as a service to patients who live far from Boston, as many of our patients do, and we provide a multidisciplinary review. This is very much prepared by a few people, and the rest of us are seeing things for the first time. This webcast is being done just like we do it every week. It's going to be very spontaneous. Most of us don't know which patients we're going to be seeing. The exception of that is Mary Beth Sylvia, who will be presenting the histories and the photographs, has spent a lot of time, as she does every week, preparing these cases. Our interventional radiologists and diagnostic radiologists spend a lot of time preparing the x-rays for our viewing, and Dr. Kazakewicz prepares the pathology for when there's biopsy slides to look at. In this case, Dr. Dr. Padwa spent an extraordinary amount of time over the weekend preparing the x-ray images we're going to be seeing, because due to the technical limitations, we won't be able to be showing live scrolling of some of our MRI scans, so we're going to be looking at them in a PowerPoint fashion on the web. We will be happy to take questions by email if there's time. On your internet, you can submit a question anytime during the webcast by clicking on the MD Direct Access button. At the end of the webcast, we have a very brief demographic survey, and we would appreciate if you would take a moment to fill that out. We're going to try and review 6 or 7 cases in the next hour and a half. We can't be certain that we're going to get to all of them. All the families have given their permission and are interested in having this done live. If we don't get to your family member, we apologize, and we'll certainly get to it shortly thereafter and get back to you. We are certainly going to follow up with all the families and physicians who've submitted information for this conference, as we always do. With no further ado, Mary Beth will go ahead and present the first case.
Patient number 1 is a 5-year-old female from Pennsylvania with a quote-unquote large vascular malformation affecting the left hip, groin, and leg. The lesion was present at birth. It became more raised and purplish-bluish in color in 2006. The left leg seems larger due to the lesion. It is not painful. And a November 06 pelvic MRI was read as quote-unquote extensive vascular malformation subcutaneously on the left side of the pelvis, extending into the medial upper left thigh. The deepest extent of the end anomaly is along the anterolateral margin of the left iliacus muscle and along the margins of the left superficial femoral artery and vein. There is no associated muscular or osseous anomaly. In December of 06, the patient was seen in consultation at a Philadelphia hospital. The diagnosis was quote-unquote veno-lymphatic malformation with cutaneous telangiectasias. Sclerotherapy was recommended, approximately 3 sessions, each session 4 to 6 weeks apart. The parents are seeking treatment recommendations from VAC, and their questions are, what is the exact nature of the lesion, what is the best treatment, and how will the lesion affect the rest of her life?
And here we see photos of this young girl. I should mention, as we're looking at the photos, that we really appreciate when families and the physicians take photos of all the relevant parts of the lesion. We also like to see pictures of the patient as a whole on their face, just to get an idea of who they are and see if there's any potential associated syndromes. You'll notice throughout this webcast, I'm guessing, although I haven't seen all the photos, that sometimes they're not of perfect focus and quality, and that's because these are families taking them in from home, and not everybody has a professional photographer, and we are understanding of that.
Steve, could I point out something before we go to the radiographs? Are we going to the radiographs next?
Why don't we talk about the photos first?
Yeah. I think it's important in any vascular anomaly to ask whether there's a family history. And in this case in particular, I'd be interested to know if any other family members have any blue or red spots. I guess we don't have that information, but it's always important to ask that. And it's also important to know whether there's any pain. It says it's not painful here, which is interesting, but I wonder if it's painful when it's touched. This kind of a lesion sometimes causes discomfort with clothes or pressure, although it's not otherwise painful.
So you're thinking that, given this purple discoloration and bulge, that this is probably either a venous malformation or maybe a glomovenous malformation?
Yes.
With the latter being painful to touch?
Yes.
Okay. I was having the same thoughts. Maybe a radiologist can give us some more information with some scans.
So this is the MRI that was submitted from the family. The initial sequence we have here is what we call a coronal inversion recovery sequence. It's fairly useful in vascular anomalies that we do some sort of sequence that suppresses the fat. This is a view from the back. We're at the gluteal muscles in the posterior, and then we're proceeding up front sequentially in the sacrum here. I will now get to the point here. You'll see up on the patient's left, the right side of your screen, just above the iliac muscle there, you'll start to see some linear increased signal in the subcutaneous fat. As I page through now, we're getting almost into the hip joint area. Up again on the left, you see that white stuff on the subcutaneous fat there is starting to increase, starting to look a little bit more linear. And then even some circular stuff that looks, as you can see there as we proceed through. Certainly it correlates with the physical exam findings that we saw. There's some areas here that you can actually see a little round gray area in some of those white circles, which may represent either some blood clot or some calcium that's in the lesion. As I go forward, you'll see some additional, and you can again see it's kind of, again, very extensive, pretty much in the subcutaneous fat, not really in the muscle or the bones, just like the reading that was supplied from the outside interpretation. As we continue forward, again, it's a little bit more of the same, but we're now towards the anterior thigh. What you saw in the pictures, again, there's a correlating finding of very high signal tubular structures, and curvilinear structures that you see, particularly on that image right there. It's very important when we do vascular anomalies that we also give some contrast agent that'll fill the blood vessels on imaging. There's a lot of motion artifact you can see from the bowel that's moving there, but this is a different projection of the axial view. Again, on the patient's left is on the right side of the screen. And you'll see again some increased signal just underneath the skin, correlating with the finding that you see on physical exam, and it's all getting very bright with the contrast that that was administered, which shows that there is some blood flow or enhancement, what we call enhancement in that area. If we use the same projection that we did for the first sequence with the same contrast administration, again, you're seeing kind of the same tubular structures now all basically very bright with the contrast that was injected, and again, showing enhancement, showing this is a lesion that has blood flow in it. But given the physical exam finding or physical findings from the pictures, certainly these findings would be also very consistent with that of some type of venous malformation. Certainly, the issue of pain would be very important to see if we can.
Well, it's interesting. Sorry to interrupt, Harry. I just got an email. This is either from the family or from the physician. I think it's from the family who must be watching, and it says there's no family history of this issue. And I guess this really works live. And it has not been painful to touch until last week. Okay, so it's interesting because I think John and I both looking at the photo, we're wondering if this is a glomovenous malformation, but maybe we're leaning more towards a venous malformation.
Glomovenous or GVM, we often call it, just because we're so busy, we use abbreviations all the time. Now, Harry, you said venous malformation, but can you tell the difference between a sporadic venous malformation or a glomovenous malformation on these images?
There's always some characteristics of glomovenous. They tend to be somewhat a little bit more punctate, rounder. This really has kind of more channel-like and tubular type structures that you usually see in more sporadic venous malformation, but it's sort of, we've also seen what we've called what looks like regular sporadic venous malformation, but it's very painful to the touch, and it ends up being probably more glomovenous malformation and vice versa. So that's why I think it's very important when we look at the imaging, it's very important that you really correlate that with the physical exam findings and what you're seeing in history.
Well, we may have stimulated another email here. We'll take a couple in the middle. We may have to wait to the end for most of the rest. And the question, I think Dr. Mullen can be the expert answering this one. Are venous malformations and vascular malformations genetic? Get into your question of is there a family history, and why do these occur? Maybe you can tackle that briefly.
Many years ago, when I wrote a book on the subject, I had no idea that many of these things were familial or ran in families. And still to this day, most don't run in families. We call them sporadic anomalies or malformations. However, over the last 10 years with my colleagues, particularly Dr. Vikula and others, genes have been found that cause several vascular malformations. In the venous family, we know a gene called TIE2 that causes familial lesions, which are venous in the skin and in the mucosa, but not in the GI tract. This is fairly uncommon. The most common familial venous malformation is the one we're talking about here as a possibility, glomovenous malformation. The gene is known, it's called glomalin. It can be tested. And in this particular child, if the family wants to, genetic testing can be done. There's another way to do it very simply, and that's Dr. Kasakovich has a biopsy of a venous lesion. He can look for gloma cells, and that can be done in any hospital. I'm not suggesting we biopsy this patient. Now, there are several other genes. Dr. Vikula has found a gene for capillary malformations in association with arterial venous malformations. The gene for hereditary hemorrhagic telangiectasia has been known for a long time. Genes for intracranial vascular venous malformations are known, and there are several others.
The hereditary lymphodemas have mostly
been
identified.
The most common hereditary lymphedema, primary lymphedema, is known.
So maybe we should see what the group thinks we have here and what can be done. And as always, we recognize that we are looking at photographs and images, and we're not touching the patient, and we haven't had a chance to take a full history and physical. So our thoughts at this time are always preliminary. We always make a habit of explaining that to the referring physicians and the families that we haven't really done a full history and physical, which we're always happy to do if somebody comes to visit us. But we like to give as much of our combined experience as possible at a distance. So what do you think, Harry or Ahmed? Do you think this could be treated interventionally?
Well, this is very amenable to sclerotherapy, with a little risk of, because it's involving the skin, it's a little bit at a higher risk of developing blisters or ulceration after sclerotherapy. It's a typical form of venous malformation, by the way. I have to comment on the imaging. It's not similar to any of the venous malformations we commonly see. These are just a bunch of dilated ectatic blood vessels, and the channels that involve the skin are very peculiar because we usually don't see them with common venous malformations. They involve the skin, like with the venous discoloration that we see, but to see a big vein like this is probably very uncommon.
So you don't think it looks like GVM either?
No, not imaging-wise. Would you guys both agree that it is a venous malformation, though? Is there some doubt? I saw one case similar to this one, and it was an involuted hemangioma that left a lot of veins, plus a lot of cutaneous veins. And if you look at the skin, this is just the one case I treated a year and a half ago. It looks like this. I'm not sure whether this is just what's left after an involuting lesion or this is a primary lesion. It would be good to get some older photos. Older photos from the family.
Because
you
only see veins, and the skin, you see also the same veins through the skin. You see the channels themselves, which is something we see sometimes in some of the involuting lesions. Well, this lesion was present at birth, and I presume that's accurate and is grown with the child. So are you thinking of the veins that are left over after Riche
After
goes away?
Riche, or so, yeah.
Yeah, to me, they're really just large veins and kind of a depressed area of skin. This is bulging out. I think it's most consistent with a venous
With the
malformation.
venous?
I'll still hold by likely possibility it would be GVM, and I would, if the family was interested, molecular testing was done. The family should also know that if it is GVM, this is primarily a skin lesion, whereas a lot of the other venous malformations can present in other organ systems and in the GI tract. So it is important to know which type of VM it is, and also in terms of treatment. So you suggest sclerotherapy.
I would suggest whether it is a GVM or VM, it certainly...
Or even veins left over from involuted breed.
All are amenable to sclerotherapy. Again, with what I agree with Dr. Alamari, the skin issue is certainly an issue, but certainly, with the options of surgery and otherwise, it could also produce some scarring and stuff like that. I think a first-line treatment, certainly a sclerotherapy
So would she benefit from baby aspirin?
I was going to ask the same question. If they don't want to have sclerotherapy now, would you just put her on aspirin at age 5?
Well, if she wasn't in pain, I don't think any of us would think about it.
She's having
the pain.
If pain continues.
Last week.
Patient recently developed pain. Yunula, would you comment on the use of aspirin in a 5-year-old?
I guess there are risks with using aspirin in the 5-year-old, and we don't use it unless the pain is consistent. If this is just a flare in which a small amount of phlebitis has caused a transient pain, I would probably not recommend aspirin.
Yeah, I think I would agree. I mean, if they've gone 4 years and 11 months without pain and had a little pain here, I would want to see a little more history before we committed to that.
Yeah.
Okay.
Those channel-like ones usually unlikely to form clots as compared to the spongiform ones.
Yeah.
Those are channels, and the flow in them is usually better than the flow in the spongiform form.
Okay.
So
Well, maybe that's
I
why
agree
it's
with
painful.
Yunula White.
And the pain may resolve immediately after some sclero and reduction of
Sure.
all these channels. The phlebitis may resolve.
It'd be interesting to see what happens at puberty. Sometimes these flare up at puberty, but we've got
Right.
a long time before that.
Yeah,
Maybe we should move on to the next case.
Well, the parents have also asked how the lesion will affect the child the rest of the life. I guess we should say that these lesions do not go away. They don't disappear after sclerotherapy. They do stay, and then they wax and wane throughout the life. They can get worse during puberty with trauma, but usually they subside again.
Very good. Mary Beth?
Okay. Patient number 2. This is an 11-month-old male from Colorado with quote-unquote possible Proteus syndrome. Patient was born full-term. Prenatal ultrasound suggested one arm was longer than the other. However, repeat ultrasound was normal. At birth, hemihypertrophy and quote-unquote hemangiomas were noted. The left side of the face, left ear, left side of the tongue, and the right foot were larger. Staining was noted on his nail beds, bilateral lower extremities, and the right side of his chest, back, and pelvic area. Mild hypotonia was noted. A neurological exam was normal. In May of '06, a renal ultrasound and chest x-ray were normal. In the same month, an echocardiogram noted a small PFO. At a well baby checkup in June of '06, macrocephaly and a left hydrocele were noted. A June '06 brain CT without contrast showed no intracranial abnormalities. In the same month, in June of '06, a head ultrasound was normal. Scrotal ultrasound confirmed a left-sided hydrocele and a non-descended right testicle. July '06 upper GI series was negative. The patient was seen in genetic consultation in June of '06. High-resolution chromosomal analysis was normal, and a FISH 7q11 for Williams syndrome was normal. Ocular exam was normal. Family history was non-contributory. Developmental history was normal. Height and weight were at the 50th to 75th percentile, and head circumference at the 99.93 percentile. An 806 brain MRI showed quote-unquote cerebral volume asymmetry with the left cerebral hemisphere larger than the right. No malformation of cortical development was identified. No abnormal enhancement to suggest Sturge-Weber syndrome was seen. In August of '06, an MRI of the orbits, face, and neck without contrast showed quote-unquote asymmetric subcutaneous fat in the face, more prominent on the left side. He had a genetic follow-up in August of '06. More quote-unquote hemangiomas were noted on his right cheek and elbows. A 3 by 2 centimeter lipomatous lesion was noted to the left of the umbilicus. The left third, fourth, and fifth fingers and the right second, third, fourth, and fifth fingers were enlarged. There was a leg length discrepancy of 1.5 centimeter with the right leg longer. The right thigh, foot, and calf were larger than the left. Subcutaneous fibrotic masses were noted over both anterior tibias. Multiple quote-unquote marbled, patchy, confluent, reticulated cutaneous hemangiomatous lesions were described. He was followed up by genetics again in October of '06. The right leg was growing quickly. There were no new quote-unquote hemangiomas. The P10 mutation test was negative. In December of '06, he had an MRI of the lower extremities that showed a quote-unquote right hemihypertrophy, an asymmetric signal abnormality, and enhancement within the vastus lateralis muscles, right greater than left, nonspecific but likely representing vascular lesions. A January '07 abdominal ultrasound was done to evaluate the abdominal lipoma. It showed no evidence of a solid or cystic mass. In February of '07, he had a repeat MRI of the orbits, face, and neck without contrast that showed quote-unquote enlargement of the left subcutaneous adipose tissue from the August '06 study and asymmetric enlargement of the palatine tonsils, left greater than right. There was a small right pleural effusion with partial right upper lobe atelectasis. A February '07 repeat MRI of the brain showed progressive changes of left cerebral hemimegalencephaly. A February '07 MRI of the abdomen showed a quote-unquote large superficial left anterior abdominal wall mass, which nearly follows the adipose tissue and that may represent a mixed lipomatous mass. A small amount of ascites was seen. He had an ENT evaluation secondary to the failed newborn hearing screen. The results revealed possible loss in the mid to high frequency range in the left ear. Ophthalmologic evaluation showed normal anterior chambers and normal fundi. In March of '07, he had an EEG that was read as quote-unquote abnormal due to intermittent slowing noted in the right and left temporal regions, as well as the presence of sharp activities seen independently in the right and left temporal regions and generalized bursts of slow, sharp wave activity. This is consistent with bihemispheric dysfunction with multifocal epileptogenic potential. The plastic surgeon is seeking a diagnosis and treatment recommendations from VAC.
Well, that's anything but a straightforward situation. Now, sometimes we spend an hour on a case like this. Obviously, due to limitations of time tonight, we're not going to be able to do that. So we may need to have another, more extensive review at the request of this physician and family. But let's see what we have here. Maybe Dr. Kasser can comment best on the hemihypertrophy situation.
Well, they said hemihypertrophy, and it has several different aspects to it that I think are important.
Mm-hmm. We'll see some of the photos that might show some of that. Are there more photos, Mary Beth?
Yeah, there's a lot of photos.
There's a lot of photos, okay.
This photo just demonstrating the sort of asymmetry in the abdomen that they're commenting on in history. It's probably the best shot of the legs.
It shows that sort of typical midline split of the capillary stain up to the umbilicus we see.
Yeah, I mean, if you look at it, there's obviously a major asymmetry in the size of the legs, and there's a capillary malformation associated with it. And it's said first to be 1.5 centimeters difference. There's a second comment that the leg is growing quickly. I'm not sure whether that's length or girth or what they mean, but it is evidently growing quickly. It's a little hard to tell from that what the underlying problem is. Hemihypertrophy may be associated with Wilms tumors, but in general, associated with vascular malformation, we found it not to be. This patient's had some abdominal ultrasounds that show another abnormality of the abdominal wall, but not associated with that tumor. The growing quickly is out of proportion to just standard hemihypertrophy, and this is a little
That's a
different.
nice shot of the leg length discrepancy there.
Mm-hmm.
So I think that in itself, it's a little, it's a little hard to say what the eventual discrepancy would be without several measurements to try to categorize that. And does this guy have cardiac abnormality or high output failure or anything associated with vascular?
There's a small PFO, but nothing else by history. Yeah, small PFO is really normal.
So this is presumably a low flow capillary malformation associated with hemihypertrophy or soft tissue overgrowth. But there's much more to it than just the legs, obviously.
And it's interesting,
component.
both the leg, the abdominal soft tissue, and the face seem to be growing at an asymmetric rate. John, what do you think about the face, or you don't wait to see the films?
Well, if I just saw the face, I'd say that looks like infiltrating lipomatosis.
Yeah.
But in my differential, when I heard the history, I said, gee, it sounds a lot like macrocephaly capillary malformation, unfortunately called macrocephaly CMTC, or cutis marmorata telangiectatica congenita in the literature, which is the wrong term.
Go back to the face pictures, John.
But the kids
slide
with
94
the
or
kids
95. Slide
the kids
95.
with macrocephaly CM almost characteristically have a filtral or a nose capillary malformation, and they usually don't have this much asymmetry. They do have some of the other findings in this kid, and I think we should keep this in mind as we look at the images. But if I just saw that, that looks a lot like infiltrating lipomatosis. Obviously, he's got a lot more lipomas.
We'll go to the imaging on slide 101 here. I'm going to start out with this is a T2 scan, fairly recent, February 07. And as you said, John, right from the start, what we're seeing here basically is, again, some asymmetric subcutaneous fat in the left face compared with the right face. There may be some subtle prominence in the fat in the parapharyngeal spaces as well. As we go through, the orbits look normal. The persistence and asymmetry of the fat persists. As we get into the brain, this will be a fairly good representation of what the outside interpreters have been describing as hemimegalencephaly. Certainly you get a sense here that the left cerebral hemisphere is larger than the right side. The left side of the patient is actually on the right side of the screen. There's the lateral ventricle on that side, which is the white area, also is slightly enlarged compared with the right. The other thing that wasn't really commented on that I didn't hear about is also the gray-white matter in the left parietal lobe also looks somewhat abnormal as well as the white matter. There's increased signal in the white matter around the posterior lateral ventricle as well, which is abnormal as well. We're going to go on to...
Darren, did you see anything else in there to comment on?
Yeah, I would also add that
neuroimaging perspective.
It appeared that there was probably polymicrogyria involving the posterior left parietal lobe.
Go back
probably
to slide
on the right as well. It looked like the genu of the corpus callosum was abnormally prominent, and the white matter periventricular dysplasia that Harry commented on is very evocative of tuberous sclerosis, and that finding has been described in megalencephaly CM, so it's certainly evocative of that kind of periventricular white matter hyperintensity.
Okay.
You can see the absence of gyri posteriorly on the left, not on this particular shot, but further down.
We'll go to slide 128, and then we'll continue on with some of the other imaging here. So this is just, I put a coronal T1 here of the head, just again to kind of demonstrate the asymmetric fat that you see subcutaneously. This time, again, the patient's left is on the right side here, and it certainly shows some asymmetric fat there. I just wanted to show this is a section from the orbit MRI, just to comment on that palatine tonsil. I'm wondering again if I'm seeing a little bit more fat in these parapharyngeal spaces on the left compared with the right, which may be causing that tonsil to protrude a little bit. This is just a section from the abdomen. which again, to describe that, what they were describing is a lipomatous mass in the anterior abdominal wall. You see on the, again, the patient's left is on the right side of the screen, showing up a little bump in the front of the abdomen that's high signal consistent with fat here on T1. Also notice, actually we have a section of his right arm here, which also shows a lot more fat in the subcutaneous area compared with his left arm.
It demonstrates how these overgrowth syndromes don't, although they may respect the midline, they skip back and forth. So you can have the face big on one side, the arm big on the other side, the abdomen big on the other side, and the leg big on the other side. None of which do we really understand.
Okay. And I just kind of put this as a coronal of his body just for, I just wanted to give some pertinent negatives since the term hemihypertrophy was brought up. So you see, just show his heart is of normal situs, his liver is reasonably normal size, his kidneys are actually reasonably symmetrical. We're not at that level yet here. Here we are at the level of his kidneys, and they're reasonably symmetrical in size. I do notice also that his arms are quite long. Looking at this, looking at him on this image, so it's hard to kind of get a full assessment here, but his arms and hands look large on this image. I'll come forward again. And then we'll go on to the next sequence. This is just, again, a sequence of his legs on T1, and really kind of, I guess, shows really that what we've been describing all along, a lot of increased subcutaneous fat, particularly, again, the patient, this time it's on the patient's right leg, which we're seeing here, and it's, again, compared with the left side, is a little bit more prominent. Okay. And that's what we have for imaging.
I would just add one thing, because the family or the referring physician mentioned Proteus syndrome. In terms of the intracranial findings, the constellation of intracranial findings are pretty much indistinguishable. The only thing that would tilt you towards Proteus syndrome would have been mandibular or maxillary overgrowth, which I didn't see on the images we showed.
And then the only thing I mentioned, just in terms of the seizures, one thing we look at in the scans, as Darren mentioned, I mean, there may be a number of these little heterotopias there, but there's no focal lesion, and the EEG looks to be bilateral. And so you always look for reversible causes. Is there a focal lesion that might be associated with a seizure focus, or does the child have hydrocephalus, neither of which really appear to be present? And it might be worthwhile just to get an epilepsy consult as well in terms of management of this if this persists.
So this is all the imaging we have for this patient, right? This is all the photos and imaging?
Yeah.
Okay. So, well, as we often do, now we have a big debate about the terminology and what do we think this is. And John, you're the terminological guru. You define the classification. Do we have an answer for this one?
Well, the audience should know that we often can't come up with an answer, and so we've taken a line from Michael Cohn, and we say this is a provisionally unique vascular anomaly. We sometimes call it PUVA. I don't know that we want to call this PUVA because it overlaps with several diagnoses. The differential would include infiltrating lipomatosis. I've written about this. We see a number of these in our specialty, but it only has involved the head, and they have infiltrating lipomas. The teeth come in earlier. They tend to have little neuromas in the mucosa. So the parents ought to look and see if keep an eye on those teeth, see if they come in quicker and develop faster on the left side. But I've never seen craniofacial infiltrating lipomatosis with this extensive asymmetry, lipomatosis, and overgrowth. So it does slide into the Proteus, although I think Proteus tends to be overdiagnosed greatly. There are only about 100 proven cases in the literature, and my friend Michael Cohn has gone through these, and Lynn Bessaker, and gone through the whole literature, and it's only about 40–50% of them in the literature are really Proteus, although they're claimed to be Proteus. So my differential, Steve, would be, I'm still thinking about macrocephaly, CM we're calling it now, macrocephaly capillary malformation. The old term CMTC doesn't apply, it's not CMTC. It's a reticulated, patchy capillary stain that can be all over the body, but typically they have it in the philtrum in the face, and this kid doesn't, but maybe they don't all have to have it. I mean, none of these syndromes, all the findings aren't 100%. They could be as high as 70% or 10 to 15%. So I'm sticking with MCM because they also have asymmetry. They can have lymphatic anomalies. This child has had ascites. Isn't that correct? And a pleural
Yes.
effusion?
Mm-hmm. Pleural effusion.
They can have lipomas. They often have 2-3 or 2-3 syndactyly of the feet. And I would rely on you guys to say, are these the typical neural findings for MCM? Darren,
I would say it's absolutely consistent with that
You too,
diagnosis.
I think so, yeah.
Now, there could be another syndrome where they don't have the filtral CM and they have more fat that kind of slops over into MCM. We have seen such patients with diffuse capillary stains and overgrowth, but nothing with this much fat, and not with the brain findings that you guys have pointed out. So I think the leading diagnosis is macrocephaly capillary malformation.
I would actually vote with that because the imaging findings in the brain are the typical ones we see in MCM. The hemimegalencephaly, and actually we'd have 2 cases in the too many patients we have that they don't have the typical filtrum.
Oh, yes.
Yeah, we have 2 patients that they have the typical presentation, larger face, larger brain, the same seizure propensity, but they didn't have the typical stain of the filtrum. And they have also the body involvement, which is hemihyperplasia and port-wise stains all over.
It shows that these are often on a spectrum. This patient demonstrates why a multidisciplinary group is really important to approach a patient like this. Here we've got neurosurgeons, neurointerventionalists, orthopedic surgeons, craniofacial surgeons, interventional radiologists, general surgeons, hematologists talking all about the same patient, and we still don't exactly know what's going on with this patient. I think it's beyond the scope of the time that we have tonight to talk about all of the different treatment options in terms of the face, the neurologic issues. Ed and Darren have talked a little bit about. The one thing I would be interested in is the orthopedics, because the one thing that I find that I don't understand but seems to be most scientifically predictable is that Jim always seems to be able to get these legs to come out the same length after they reach full growth, at least in the Klippel-Trenaunay type overgrowth. Is this the kind of thing where you could predict with scanograms what age to do epiphysiodeces and get these legs to end up pretty equal?
Yeah, I think it'll take sequential follow-up in order to get the answer, but it can be done and should be done. One question for you: in some of the overgrowth syndromes or hemihypertrophy with VM, they don't need screening for Wilms tumor. Should this be screened or should it not be?
You know, I don't think the answer is in on this one. As you know, we've looked at, Aaron Green has proven pretty definitively that in Klippel-Trenaunay, as we define it pretty strictly, with the combined capillary lymphaticovenous malformation with the stains, the port-wine stain and the vesicles and all, those patients are not at increased risk for Wilms tumor above the baseline population. But I think this is rare enough that the numbers aren't in it.
So it would seem to me this should still be screened.
I think that ultrasounds are appropriate until the usual age to be certain of that. My hunch is that it's probably not the same as some of the other hemihypertrophies, but I don't think we know that, and it's better to be safe. Mary Beth?
Okay. Patient number 3 is a 5-year-old male from Louisiana with right lower extremity, quote-unquote, hemangioma versus AVM. The patient was born with a vascular lesion on the right lower leg described as oval, raised, and gray-blue in color. By 3 months of age, the lesion had flattened. The pediatric dermatologist's diagnosis was, quote-unquote, hemangioma. At age 20 months, a punch biopsy was read at a New Orleans hospital as, quote-unquote, intradermal vascular lesion with features of AVM. A second consultant's reading was, quote-unquote, lobular capillary malformation. At age 3, the pediatrician judged that the lesion was growing with the child. The parents consulted with a New York physician who requested an MRI after reviewing the punch biopsy. A June 05 MRI without contrast showed a lesion of the, quote-unquote, anterior right lateral aspect of the proximal leg with large supplying vessels consistent with hemangioma. The consulting physician felt the lesion was an AVM. Family history is significant for a maternal grandmother with, quote-unquote, hemangiomas of the liver, diagnosed 10 years ago. Currently, the lesion is not painful. The mother notes that the toenail beds are always purple, and the patient complains of tingling in his legs and feet when sitting. Parents are seeking an opinion from VAC, and their questions are his muscles affected? Is there a chance that there are more lesions, and do these lesions cause serious problems?
So look at the photographs. Certainly the history raises lots of questions in all of our minds. We like to try and sometimes guess what these are before we see the photos.
I think this is the first time we've actually gotten a picture of the vascular lesion at birth.
We've certainly taken some when we've delivered them here. In fact, I think I know what that is, and we've taken pictures of those that they've been delivered here, but it's nice for the families to send us those.
Thank you. 6 days old.
Point out that it's kind of purplish. I can barely see it, but there's a halo around that.
There's a pale halo.
Pale halo around it.
So present at birth, pale halo.
And it's looking better.
And now we're 6 months and it's flat.
Yeah.
8 months.
8 months.
2 years old. This is close up at 4.5.
Now the vessels, the veins are a little more prominent now.
Yeah, and the skin is almost depressed and a little bit of color left. Still a halo. And now it's definitely depressed with the veins. And that may be positional. When they stand up, they may fill.
So,
all right, so should we say what that is before we see any films?
I think we can help the parents out on this one.
All right, what is it?
I think we all agree, huh? This is a classic lesion that we have called rapidly involuting congenital hemangioma. Congenital meaning that it's fully blown at birth. The other characteristic is that it didn't show any evidence of increased growth in the first few days and weeks after birth, which a typical hemangioma would always do. And these lesions regress very rapidly, usually within the first few months and certainly within the first year, and leave this sort of residual depressed lesion without fat. Most hemangiomas leave fat behind. Here in Boston, we pronounce the acronym REACH, and I don't want the audience to think that that's an affectation. You could pronounce it rich. I'm from the Midwest, and we would probably pronounce it rich. The reason we pronounce it riche is because we worked with colleagues in Paris, Enjolras, and put a little French accent on there.
Michel Wassef, the pathologist who worked with Dr. Kazakewicz, I think.
Do we have a biopsy? We don't have a biopsy on this one, do we? We do.
I think we do.
Oh,
all right, let's move along.
He's the expert.
This is how we sometimes embarrass ourselves because we pontificate about it, and then we look at the X-rays and the pathology, and we're totally wrong sometimes. So let's see what happens here.
So this is an axial T2 with fat saturation. Again, a common sequence that we like to see with vascular anomalies. And in the area in question, there's you'll see along the left side of the screen, along the left side of the leg, you'll see an area of white there, which correlates with that flat plaque-like area that you saw on the screen.
Harry, what's the age? I'm sorry. Did I miss it?
5-year-old.
5-year-old.
No, but the age of the scan.
No, the scan.
The scan is recent, within the last year.
Late.
So.
Okay.
So here of note, there's a small vessel going to that area from the deep system. I have a coronal image also when we get to the end of this. This is more of coronal. This is actually those little vessels off to the left there are actually going to that area as well.
Or coming from.
Depending on how you look at it. There's a large, that looks like a large draining vein up to the upper part of it there as well. So that I would say, from the imaging findings, I would agree that this probably represents a involuting or a rapidly involuting congenital hemangioma.
Well, is it fast flow now or not? Because there was concern that it was AVM early on.
Yeah,
at age 3.
It doesn't look like it. And certainly, we didn't get a contrast study. An ultrasound would be very helpful if they were concerned about a flash flow lesion to look for arterial or venous flow.
They typically don't have a lot of flow in MR, but if you do an ultrasound, there is actually a lot of smaller vessels and larger veins.
But at 5 years now, there may just
not at 5 years though.
The residual veins now.
Oh, even if after, even the patients.
5 years?
Yeah, you see very prominent arteries. They don't come very close to the skin, but they're very prominent.
Would I hear a 2-fro with just a handheld Doppler?
You probably will. You probably will, especially in the middle of the center. There's always a couple of arterial.
You didn't see fat. You did not see fat on that.
Did not see fat.
You can pick up very small vessels with the ultrasound. Very sensitive.
But much bigger veins. The veins are always much bigger.
Yeah, there's
That's
obviously huge veins here. Us non-radiologists can see that. Harry, what do you think about the histology?
Yes, could you scroll one up, please? Yes, well, the skin surface is no longer present on this cut, but there's an appendage on the extreme left. But the dermis and the subcutis has lobules of vessels, and then you can see some larger feeders and drainers. And if you go to the last one, to the prior one, yes, there is a lobular character to the lesion. The vessels are very tiny. The nuclei kind of protrude a little bit into the lumen, a little bit like a niche. I'm not saying this is a niche, but...
you better explain niche versus niche, Harry.
Niche, non-involuting congenital hemangioma. The basement membranes are only minimally thickened. The biopsy was done when the child was 20 months. And there's connective tissue between every little capillary. From the biopsy alone, I really don't think that I could tell whether this were an involuting hemangioma, infantile hemangioma, or even parts of niche or riche. But taking the clinical and the imaging into consideration, I think it's consistent with riche.
Harry, I think we should mention that there is one test that many people put a lot of stock on.
An outside consultant performed a GLUT1, and the blood vessels were negative. And as you know, congenital hemangiomas are negative for GLUT1.
But regular infantile hemangiomas classically have GLUT1. The families asked questions and the physician about AVM. I think we can all be confident that this is not an arteriovenous malformation, which is extremely important because arteriovenous malformations have risk of ulceration, progression, more deterioration, whereas this type of, all hemangiomas, but this type in particular, does not have the potential to go on to cause more difficulty for the child. Maybe before I go to the next one, I can comment on one thing it says here, the family history is significant from maternal grandmother with, quote, hemangiomas of the liver, unquote, diagnosed 10 years ago. Well, if you're old enough to be a grandmother and you don't have a hemangioma, because we know hemangiomas are actually tumors at infancy, so, but that term is commonly used for liver lesions, and Dr. Kazakevich has proven, as we've looked at some of these older lesions, that these lesions are actually vascular malformations in the liver and not hemangiomas. So this is a happy situation here. I think in the interest of time, we should probably move along to patient number 4.
Patient number 4 is a 6-month-old female from South Carolina with quote-unquote possible Klippel-Trenaunay syndrome. The patient was born at 33 weeks gestation with purple-red staining of her left lower extremity with vesicles, along with a small stain on her left labia. There was a large pedunculated bleb on her left posterior calf. Initially, she was diagnosed as quote-unquote giant hemangioma versus Klippel-Trenaunay. As her workup continued, other specialists questioned quote-unquote CMTC versus Sturge-Weber syndrome. In January of 2007, an upper GI and small bowel series was read as normal. In February 2007, MRI was read as quote-unquote dilated vessels in the left lower extremity, extending from the pelvis to the ankle that could be arterial or venous. No evidence of tethered cord or lumbosacral mass was seen. The patient has bleeding from the vesicles that ceases with pressure. There have been no infections to date. In March of 2007, she saw an orthopedic surgeon who noted no hemihypertrophy and no bony involvement was seen on the MRI. She recently consulted with a plastic surgeon for evaluation of the bleeding episodes. He noted the left lower extremity to be slightly smaller than the right. He diagnosed quote-unquote Klippel-Trenaunay syndrome and referred her to VAC for possible sclerotherapy and/or laser treatment. The parents' questions are, do we agree with the diagnosis? What can be done to prevent future bleeding? How will this affect her ability to walk? And will she be able to participate in sports and physical activities as she gets older?
It's really nice to have photos at one day of life.
Ah, there are the vesicles first seen.
That's a pretty baby. And now we see the change in coloration. That first day,
Yeah.
sometimes with all the changes that go on with delivery, things look a different color. And then as things mature and sort of the rheologic status
Well,
stabilizes,
babies are all red, and you got to wait till that goes
Yep.
away. Those vesicles are fairly large. One of them in particular.
yeah. And those are the type that tend to bleed sometimes,
Yeah.
and maybe portals for infection in later years.
Very impressive. They're rather scattered. Usually they're more mat-like in a patch. Makes you begin to wonder.
So moving on to the imaging, this probably was a study done essentially sort of what we would call like a vascular type of study, which sometimes we wouldn't necessarily, with this type of a vascular anomaly, would treat like a vascular study to just basically study the blood vessels. It's also very important to study kind of all the other tissues around the blood vessels in order to kind of make the diagnosis. So I tried to kind of get some of the representative images here. I just wanted to show kind of a coronal of the legs just in general to show that they still remain relatively symmetric at this point. The fat content may be a little lower on the left versus the right, but otherwise remain symmetric, and the muscles look, at least on this particular sequence, look reasonably normal. What I wanted to show is this is just an axial T1 from the vascular study that they did. We're starting at about the level of the lower pelvis, upper thighs, and as I go down, you'll notice that on the left of the screen, this patient's left leg is on the left here, or is on the right side of the screen. I'm sorry. You'll notice there's a white dot that's on the lateral aspect of the left leg that you look at the right leg that doesn't have that. That is really a finding consistent with what we would call a lateral vein of Cervelle that we see pretty commonly in Klippel-Trenaunay syndrome. As we go down, I want to also take note in the middle of the leg, you'll see a second white dot that's in the muscles. On the left, you see one dot, but if you look on the corresponding side of the other side, you only see two dots. I believe one of those on the left, on both sides, one of those dots represents an artery, but on the left, it looks like it's missing a dot, which I believe would be a hypoplastic deep vein on the left leg. Again, that would be consistent with a diagnosis of KTS. And as we move down again, we're in the popliteal region at the end of the femurs. Again, same thing. You have two vessels behind the knee on the right, and then only one on the left. Again, consistent with that diagnosis. And then this is just one representative of the MRV, again showing the lateral vein on the left. Though here it's a little bit more posterior. It's a little bit hard to project, but there are two little dots of vessels on the right leg again, and there's none on the left side as well. And again, that's pretty. It was done sort of like a vascular study, and that's the imaging that was sent to us.
Diagnosis?
We all agree?
Everybody agree? We've got the right diagnosis here.
We may not agree with the term, though. We're trying to get rid of the dead European males. So, although KTS is so embedded in the nomenclature, it's kind of hard to get rid of it. But often our group calls it CLVM because I think it more accurately tells you what...
For capillary lymphaticovenous malformation. And Klippel-Trenaunay is pretty well established and accepted, but it's certainly important to distinguish it from the useless term of Klippel-Trenaunay-Weber,
yes,
which is an inappropriate bastardization of Klippel-Trenaunay and Parkes-Weber put together. Both are with people with the big red purple legs and vascular malformations, but Parkes-Weber is much different in that it has high flow, which can be of great significance.
But some groups are not quite as strict, and they may well be right, but they call large capillary stains with some abnormal veins without lymphatic anomalies, they'll call that KTS or CVM or CLM. So I think we all agree. But I wonder if anyone was bothered by the fact that the leg was smaller. Most people think that CLVM has a larger leg. Jim?
I think the thing that was strange, about 10% of the legs in Klippel are shorter.
Yeah.
So they're not all overgrown in length. Most of them are overgrown in girth, but I think I've seen some that are smaller. One of the interesting things about this one is that the transverse sections through the muscle showed the muscle to really look quite good. And many of them have a major lymphatic component, I think. And this one, perhaps that would go along with better function because you did have a good muscle envelope. You do have relatively normal-looking joints to the extent I could see on the...
Well, time won't allow us to answer all the questions and all these patients that have been asked us by the families and the physicians, but the family did ask, to address that question, how do you think this will affect her ability to walk and will she be able to participate in sports and physical activities as she gets older?
So they want to know what happens at puberty, too.
Right. How would you think as she grows we're going to predict
Can
this?
we look at just the pictures of the feet and the calf again?
We're going to go to
I
slide.
mean, to some degree, it depends on what the extent of deformity is, the range of motion, and the muscle strength. The MR shows a muscle envelope that really looks
slide
quite
227.
good. But I'm not sure. I mean, they did see an orthopedic person who said they didn't see hemihypertrophy. But many times there's very significant foot deformity that's associated with this. And I think that may have a major component. These feet, this really looks quite good. Just from my perspective, it does look like the left side is a little bit shorter, as well as the girth being perhaps a little smaller.
Yeah, it certainly goes with the imaging, showing a little bit less fat in that area, but I agree with the degree of muscle involvement, at least at this point in time, looked reasonably low. And what the concerning thing really was just the venous system, at least on the vascular study that I saw.
Steve, as you well know, a lot of these extend into the pelvis. And there was a stain around the perineum. Did you see anything in the pelvis, or was that not imaged?
I really studied the leg.
Well, that should be considered in the future.
Yeah, when the child's older, it might be relevant to look at a pelvic exam and pelvic imaging. But most of these patients, even when they have extensive pelvic involvement, are able to have normal bodily function. Sometimes there's some bleeding issues that we can deal with.
A couple of things about the vesicles, the lymphatic vesicles that they ask about how to treat them.
Yes.
I think both direct alcohol sclerotherapy and CO2 laser photocoagulation can take care of them. They may have to be repeated or done a couple of times.
And a lot of patients with CLVM have problems with their vesicles, and I think we all sort of noticed these very prominent bleb-like vesicles, and I think this patient may be sort of an earlier candidate for those kind of interventions than most patients, because they may get in trouble with bleeding.
And wrapping, of course, helps those vesicles, but I would agree with you. I think sclerotherapy. I think I'd favor sclerotherapy over CO2, but they both are going to come back. It's just a question of repeated treatments.
Mary Beth, why don't we move on to the next patient number 5?
Patient number 5 is a 5-month-old male from California with quote-unquote Bean syndrome, also called blue rubber bleb nevus syndrome. A 2 by 2 centimeter scalp lesion on the anterior fontanelle and multiple tiny red lesions on the trunk were seen at birth. The scalp lesion was described as dark, reddish purple, and hard. It bulged when the patient cried. Family history is significant for a brother and a great uncle with quote-unquote hemangiomas. At 5 weeks of age, the patient presented with acute hematemesis and melena. Upper and lower endoscopy revealed a quote-unquote normal esophagus, multiple red gastric lesions consistent with hemangioma, and a few duodenal hemangiomas along with multiple small red lesions consistent with hemangiomas throughout the colon. No biopsies were done. In January of 2007, abdominal and pelvic CT was read as quote-unquote normal, with no evidence of organ, bone, or soft tissue hemangiomas. The January 2007 brain CT was normal. The patient has had no chest imaging. January 8, 2007, labs showed normal coagulation studies. Hemoglobin was 8.3, hematocrit 25.7, platelets 167. A February 2007 abdominal ultrasound was quote-unquote negative for liver hemangiomas, and the spleen was small. In February, repeat labs were done. February 26th, the labs showed hemoglobin 5.9, hematocrit 16.7, the platelets were 88. 2 days later, the hemoglobin was 10.2, hematocrit 30, and platelets 45. The patient required several transfusions between 1 and 4 months of age. He has had 4 sclerotherapies with alcohol, with quote-unquote mild improvement of the gastric lesions with unchanged colon lesions. The patient was treated with prednisone, 2 milligrams per kilogram, from early January to the end of February. Although the patient did not require a transfusion while on prednisone, the prednisone was discontinued because it had no effect on the lesions. The most recent bleeding episode was last week, 2 weeks post-sclerotherapy. The patient required a transfusion. Current medications are sucralfate, Prevacid, and iron. The patient was referred to VAC by the pediatric gastroenterologist at the request of the parents. Their question is, what other treatment is available to prevent GI bleeding other than monthly or bi-monthly sclerotherapies?
So here's a photo of the skin lesion on the scalp. I think all of us would probably raise the question that, blue rubber bleb nevus syndrome, a multifocal venous malformation, is sort of one of our pet conditions that it's a very rare condition that we've treated a lot here in our group, and it doesn't often present in a 5-month-old, although it can. We've even seen some before birth on imaging, but I think I'm already suspicious of this diagnosis, and I don't know, Victor, from GI, what do you think?
Yeah, well, I think we need to look at some of the endoscopic images, which are a little more telling, but just looking at that skin lesion, it's a little dark and unusually oval-shaped for the lesions that are seen with blue rubber bleb nevus syndrome. So it's very atypical.
And a little early, too.
Despite the age, just the morphology is very unusual. The color and the morphology would be very unusual.
And that was present at birth and has remained unchanged over 5 months?
And some other ones have come up on the trunk.
Okay.
Yeah, it's very hard to see any other obvious skin lesions on these pictures.
They don't project as well in the pictures. There's a little dot there.
In the lumbar region.
In the lumbar region in the back.
When you look at them closely, they're not very reddish blue. But they're very hard to see on these pictures.
Okay. What do we have for imaging? We're all suspicious here.
Yeah, we should.
Well, imaging really in this is not unfortunately not very helpful. There was an abdominal CT that was obtained. The spleen is maybe a touch on the small side, but it's also a little bit rotated as well. But the rest of the solid organs look normal. He was a very good drinker. It looks like he got the oral contrast down well, and the bowel actually looks reasonably normal, and I don't see any cutaneous manifestation, or at least any radiological evidence of the cutaneous manifestations here. And just for completeness sake, there was a head CT done, and the head CT was also normal. In the endoscopy pictures.
Yeah, so also the fact that those are negative wouldn't necessarily exclude a diagnosis of blue rubber bleb nevus syndrome, since often they're very subtle lesions and you might not see them on cross-sectional imaging.
Yeah, most patients will have some in the liver, but not all of them, and some retroperitoneal. But I think at this age, all bets would be off for cross-sectional imaging for that condition.
So there are a series of endoscopic images we're looking at. This one in particular shows in the stomach a slightly raised lesion. It's sort of somewhat reddish colored. It doesn't have very discrete margins. Again, in looking at this and comparing it with what we've seen with blue rubber bleb nevus syndrome, which is a multifocal venous malformation lesion, these don't have very well identified margins. They're almost like little red smudges, and there is a cluster here we're seeing in the fundus of the stomach. Again, very, very subtle. This one is a flat, almost smudge-like lesion. Again, here's a similar type of lesion in the colon. It's flat, not very well-defined margins. These are probably the best, I think, representative pictures we have of what is present in multiple images. They're slightly raised. They're mostly reddish color. In the Bean syndrome, they're typically darker colored.
These look red, almost like hemangiomas. Look very reminiscent of a patient that we saw years ago, which was turned out to be something else.
Yes, I think that's what this is going to be. And here we see a broader cluster of these lesions in the stomach. So the description, though, is that of hemangioma. Apparently, that's what the examiner described, and I would agree. These features are typical of a hemangioma-like lesion. Here's a slightly reddish smudge. That raised area that you're seeing is actually the ileocecal valve in the cecum, so it's not really a lesion, but doesn't project very well, but there is a little bit of involvement on the tip of that ileocecal valve as well. So we're seeing this multiple lesions, some of them slightly raised. There can be clustering. They don't have sharp margins. Here's one near the pylorus of the stomach. We're not seeing them actively bleeding. They may be increasing a little bit in number over time, but overall, and there is a series of endoscopic images over several months that don't show very significant change either in the distribution, the pattern, or the size of the lesions. I think the examiner I would agree with the term that they used, a hemangioma-like lesion in on the mucosal surface.
Victor, do these lesions look anything like cat?
Yes.
Yeah, I think that's what we're all probably getting at. We don't have biopsies to look at, right, Harry?
Yes, we do.
No, we don't.
No.
Unfortunately,
So,
we don't.
so we don't have the definitive histologic diagnosis, but this patient has the low platelet count and is anemic. Now, any patient that has bleeding in their stool can become anemic, of course, and can even lose platelets, but it's not typical of GI bleeding. But this cat lesion that Dr. Clement mentions is something that typically presents with stains on the skin, which look just like this sort of more brownish purple stain. I think we all agree that
doesn't look like
the thing on the
hemangioma.
scalp does not look like hemangioma. The things in the gut look exactly like hemangioma, although true hemangiomas in the gut are quite rare, not quite as rare as this cat. Maybe Harry Kazakevich, since he described it, can tell us what cat means.
Well, actually, Dr. Mulligan named it, so.
Well, we'll always argue about the names.
You had 2 C's in it, I think. I took one of the C's out.
Continued visceral angiomatosis with thrombocytopenia. It's also known in the literature as multifocal lymphangiendotheliomatosis with thrombocytopenia. But I think, and I think it encapsulates the 3 features. Number 1, the lesions are congenital. Number 2, they are the children do have thrombocytopenia. Number 3, the lesions are continuous and visceral, and the extracutaneous lesions are usually pulmonary and GI.
Mary Beth, do we know if there's been any lung imaging or any coughing of blood?
There wasn't any lung imaging.
And no history of any coughing of blood.
No.
So that is something, it's very rare for us to see, especially at this age, to see vascular lesions in the lung. And when we do see them, we think very quickly of this cat lesion. And I don't know. You think we ought to, Victor, recommend that they get a CT scan?
Definitely.
I
think that several of the group that we described had pulmonary lesions. I don't know whether we would detect them easily on a chest X-ray. They might just start with a simple chest X-ray. But I think a CT scan is going to
actually need CT scan.
There have been some we've seen them on X-ray,
right.
but if it doesn't show an X-ray, then a reduced dose, infant CAT scan of the lungs might be worthwhile to follow this. Now, what about treatment?
Yes.
Okay, so
I guess the only reason I asked is because he was on steroids, and most of our CAT patients actually had responded to steroids, and I get the impression from them that this child did not.
Well, I don't know about that.
So he stopped bleeding while he was on there.
Yeah, exactly.
Okay.
I mean, what the conclusion they came to was based on the fact that there was no morphologic change. But the interesting
I see.
observation that we've also made is that we don't see a dramatic morphologic change when we re-examine either the skin or the gut, but we see clinical change in reduction in bleeding.
Platelets.
Yeah.
we see the platelets come back up near normal, and we see the clinical bleeding stop.
Yeah.
Which they did see.
Which is important in the gut and extremely important in the couple patients we've seen with bleeding in the lungs, who have coughed a lot of blood, and so the skin lesions don't really change much at all with successful treatment. So we really define the endpoint as the bleeding clinically and the platelet count. So steroids might be a good option to go back on long-term chronic steroids. What kind of dose would you think?
Well, the 2 milligrams per kilogram was a very good dose.
To start at.
I would try to wean it to the minimum tolerable dose, so I would go to 1 milligram, whether or not that holds.
And some of these patients have needed longer term treatment than some of the other standard hemangiomas.
But I would base it on the platelet count. I would also look at the parameters of the platelets, because most of our patients with CAD had very small platelets, and functional studies of the platelets, if you want to tell them, Mary Beth, that platelet aggregation studies need to be done as well, because they are abnormal in these patients. if he doesn't respond to steroids, yes, then we may consider other drugs that are more experimental but have certainly worked in the 2 cases that we have.
Or we had to stop steroids for.
Right, that couldn't tolerate steroids, and that's thalidomide. And I can certainly guide the physicians if they need to with how that is dosed and how that is increased.
Right. So this is a really, really rare condition. I don't know that we need to biopsy this to prove that that's what it is.
I was wondering about that. I mean, the first thing that grabs your attention actually is the scalp lesion, because a number of our patients have had, what you might call a herald lesion, a herald patch. I mean, on the scalp, on the back, we had one with an oval-shaped lesion on the back, one on the bridge of the nose. So it's very characteristic.
Are they fast flow?
I don't think so, although I'm not sure that we.
Well, they're vascular tumors.
Well, they're very small to characterize in cross-section. So if you want to study them, it's probably better to put an ultrasound probe on it, small linear probe
on the scalp lesion.
And it's also good to start or to study the lung lesions, because those are the ones that actually responded to the steroid treatment.
We've seen those disappear.
That's true. That's true. Yeah. We didn't see that in the gut.
They tend to disappear a little bit faster than the skin one. And it's true that there's always a dominant lesion.
But the biopsy was, but coming back to your question about the biopsy was very unusual and somewhat characteristic of this lesion. And it was atypical, I think, for what Harry has seen with other common hemangioma. And I think it could be done safely. I mean, you could biopsy endoscopically. And I wanted to come back to the comments about the endoscopic therapy that was rendered, because I think sclerotherapy was probably used because these were thought to be venous malformations and this blue rubber blood nevus syndrome, for which people have done sclerotherapy. But this is a small capillary type malformation. I'm not sure exactly how we categorize this thing, because it's a little bit like a tumor hemangioma, but it's a little bit like a malformation as well. It's sort of a hybrid lesion. But I think sclerotherapy is probably not a good type of treatment for this. One might consider, to reduce the burden of lesions in the gut, if they're reachable with a scope, to do some kind of superficial cautery type therapy with multipolar coagulation, or even argon plasma coagulation with a probe. So the goal here is to eliminate the amount of bleeding to reduce transfusion dependency, which ultimately we think may need steroid therapy, but it's possible that if you reduce the burden enough with some local endoscopic therapy, you might get there as well. But that might be an opportunity to take a biopsy and cauterize the site and have something a little more definitive.
And I would think that a biopsy endoscopically might be a good thing to do initially, and then if there were lung lesions on imaging, that might be the easiest thing to follow clinically along with the platelet count, rather than doing repeat endoscopies. We just got an email from, it says Pete's GI, I assume this is this patient's doctor who referred them to us, and it says Cat, ? Please repeat the name. So we would call this, Dr. Mulligan's the expert. So.
No, Harry, go ahead.
Say it slowly now.
You have to speak loudly this time, because I didn't hear it the first time.
Cutaneous visceral angiomatosis with thrombocytopenia.
And the doctor does say that he was better on steroids. And if we biopsy, what should the pathologist look for? Well, that would take an hour for us to describe, and only Dr. Koskevich would understand it, but he wrote a paper describing this, and there's another paper in the literature on this now as well by Paula North. But Dr. Koskevich, I'm sure, would be happy to review the biopsy. If I can speak for him, we do that all the time.
Or perhaps a punch biopsy of the scalp lesion is accessible.
Either way, I think the diagnosis could probably be made histologically.
Did the lesions finally go away when steroids withdrawn and everything's fine, or what was the course?
We've never seen complete disappearance endoscopically. Cutaneously, I don't think completely.
We've never seen all the skin lesions go away either.
We have not seen the skin lesions go away. The lung lesions, even though they regress, you can still, if you know that's where it was, there is still, either that is scar tissue or what it is, you can still determine where they were.
But we've seen dramatic resolution. We have a patient who had hundreds of these, and I did thoracoscopy, and we had multiple sort of marble-shaped lesions throughout the lung. We biopsy one, and then when we followed on scans, now if you looked at them years later, you would have to compare the prior scan to say, yeah, there used to be something there, but it really looks like they've disappeared.
So how do we categorize this lesion?
You mean tumor versus malformation?
Well, I thought Harry favored the tumors origin of these in his paper.
So do I. They behave
They
more
behave
like
like
tumors.
tumors.
They
And they
behave more
respond to
like
treatment
tumors.
And
like
they
tumors.
consume platelets like the composite form hemangiomas endothelium does. It really behaves like a tumor.
Yeah, they behave more like tumors.
All right, we're getting a little push for time, so why don't we see if
Okay.
we can get another case or maybe two more in before we're off live, and then we can finish the rest later. Maribeth?
Patient number 6 is a 15-year-old female from Maryland with quote-unquote AVM of the left temporal brain. Patient presented with severe frontal headaches in March of '07. CAT scan showed left temporal parietal hemorrhage. Angiography revealed an AVM situated in the mid portion of the left superior temporal gyrus. Embolization resulted in quote-unquote 50 to 60% obliteration of the AVM. Further recommendation is gamma knife treatment because the AVM is in her quote-unquote dominant language function temporal lobe and there is deep venous drainage. The patient continues to have headaches and neurological deficits, including expressive aphasia, fine motor problems with her right hand, and a right temporal homonymous visual field deficit. The right visual field problem began after the embolization and quote-unquote appears related to swelling in the vein close to the optic nerve. The patient is currently being weaned off corticosteroid but continues on anti-seizure medication. Family history is not available. The patient was adopted. The parents' questions are what combination of embolizations and gamma knife therapy is likely to produce the best result, and is the right visual field problem a result of the AVM or the procedure, or could another vein be involved?
We only have the one picture. The rest is imaging.
It's a little hard to take a picture of the brain, so I guess we'll excuse them for that. She's a
we'll
beautiful girl, I'll give her that much.
You take a picture of the brain like this. So this a CT scan, I presume at diagnosis. I would defer actually Dr. Orbach if you want to chime in whenever you want as we go through here. Head CT without contrast in brain windows, basically showing as we go through a focal area of increased attenuation in the left temporal area, most consistent with an active hemorrhage. There's some peripheral low-density material consistent with a little bit of edema. Not a terrible amount of shift at this point. The cisterns look still reasonably open at this point. And the ventricles are of a normal size. We'll start now with this is the diagnostic angio. Start with the left internal carotid artery injection. Basically showing in the area seen in the CT scan a focal high flow lesion, multiple tangled vessels with early venous drainage. That's the view from the front, and then we have a lateral view here. And kind of demonstrating high flow with AV shunting. This is just a magnified view of the same run.
And it looks like the supply is largely from the left MCA anterior temporal branches with a more minor supply from the left anterior carotid artery. The venous drainage looks like it's primarily deep via medial temporal veins into the vein of Galen and the straight sinus. But there was also a very long cortical vein that extended for quite a distance before it spilled into the superior sagittal sinus, which may have some prognostic meaning as well.
Just for completeness sake, the right ICA was injected and showing very minimal supply to that area on the right. And this is just the lateral view of that right ICA injection. Then they proceeded to use NBCA glue for embolization, and then maybe Dr. Orbach, you want to just comment on the...
So it looks like they're catheterizing one of the MCA branches here, and I see what looks like intranidal aneurysms with some of the nidus opacified, and then it looks like there's a long stretch of normal MCA opacifying from here as well.
Frontal view.
I'm sorry, intranidal aneurysms?
Yes.
I hadn't heard that term before. So there's aneurysms within the malformation?
Correct, and that's one of the risk factors that we look for rupture in the near term and would cause us to be more aggressive in pursuing treatment if there are. The two types of aneurysms typically associated with AVMs are either intranidal aneurysms or flow-related aneurysms that can be at some distance from the nidus, but on a feeding vessel. And the flow-related aneurysms occasionally may resolve when the AVM is treated, but the intranodal ones are usually treated more aggressively.
And usually in kids, you know, I mean, in terms of questions, one of the first questions I think the family asks is, should we treat this, and if so, how? And when you look at risk factors for AVMs, I mean, there's a whole list of things we look at, but this has a number of them. As you mentioned, it looks like it's a high flow lesion. You know, the venous filling is pretty fast. The other suggestion the high flow lesion is the carotid is fairly large and the MCA is fairly large on that side. The other worrisome factor here is that, as Darren mentioned, there are some venous aneurysms. You know, basically the veins get stretched through the high flow that goes here, and that may be related to why she bled. And then the other thing is, I also wondered, I don't know, Darren, if you saw it, but I wondered whether there's a little venous stenosis on one of the cortical vessels,
yep,
which is another risk factor where the blood comes in and it can't drain as quickly as it could. So I think there are a number of risk factors here that suggest, you know, that this would be at risk for bleeding, which it did, and it also, I think, implies a little bit of an impetus to treat this. You know, certainly given that she's a young girl, her rebleeding rate is relatively low early on. It's somewhere, depending where you read, between 3 and 10%. Here it's about 6% per year, so it's pretty low, but it adds up over time, particularly in an AVM that's hemorrhaged. So I think there is some impetus to treat here.
I would absolutely agree. That deep venous drainage and that long cortical vein with the stenosis that Ed pointed out, I would probably even put the risk of rehemorrhage higher than Ed just mentioned. They asked questions about embolization, and in the setting of brain AVMs, embolization has 3 potential roles. The first is possibly curative, and that's the minority of lesions, if there's a single feeder or just a few feeders and a discrete nidus. The second is if surgery is contemplated, then an aggressive embolization, particularly aimed at the deep supply that's not accessible surgically, would be contemplated. And then the third would be in the setting of radiosurgery, and that would be particularly targeting the aggressive morphologic features like intranodal aneurysms or venous ectasia. So that would be my strategy in looking at this AVM. The issue with radiosurgery is that the involution of the AVM takes 2 to 3 years, and one would like to protect the patient during that time. So that would be the goal of embolization in that setting.
Yeah, I think we're just noting here, one of the questions here is about the symptoms on this patient, and I think well, in terms of the vision and the weakness, I think clearly the speech is related to the fact this is right in Wernicke's area, which is one of the speech centers for the brain. Talk about an expressive aphasia, which is problems getting the words out, but I wouldn't be surprised if this child had a little bit of trouble with either a conduction aphasia or receptive aphasia, you know, problems understanding language as well, and hopefully that may improve over time since the brain is so plastic in younger kids, and as the clot retracts a little bit, takes some pressure off. I think just time will tell. And in terms of the vision, you know, regardless of the setting of it, whether it was related to some swelling after, you know, the embolization or just the hemorrhage itself, I think Meyer's loop was probably involved here, which are the big fibers that loop back from the lateral geniculate nucleus as it goes back to the back part of the brain, and they sit down there in the temporal lobe. So I suspect that that's the reason for her visual problems. And again, I wouldn't be surprised if some of the visual problems on the right side persist, but they may again improve as the swelling goes down. There's a fair bit of hemorrhage in there, and I think one thing that I would recommend, and I don't know, Darren, your thoughts, but I think it'd be useful in terms of planning strategies for treatments, whether it's radiation therapy or anything else, to get an MRI to look at this thing and get a sense, once the clot's retracted a little bit, what the anatomy is like in there. Look at it in 3 planes, because we've seen the CAT scans, but as helpful as the angiograms are, it's often good to put it in the context of sort of what the brain looks like in there.
Absolutely.
I'll just go through the rest of the imaging. This is the embolization. They catheterized at least 5-6 vessels at least. It looks like they injected glue into at least 3 of them. And then this is the post after the second embolization. Still a fair, I mean, some exclusion there, but still a decent amount of shunting. That's the lateral view. This is the post-embolization after all the embolizations were done. Again, definitely a lot of exclusion compared with the pre-embolization, but still is a fair amount of shunting, and I still think you see the intranodal aneurysms that you guys were talking about. And then this is just the frontal view, again showing those findings. And then we'll go on to they did a head CT. Immediately, looks like immediately post-embolization, still showing some clot in that temporal lobe, but also demonstrating there more immediately the glue that was deployed. Certainly would be consistent with what Dr. Smith said in terms of the areas that were affected. And and certainly, again, whether a lot of the symptoms were secondary, because there is still present a lot of edema secondary to the hemorrhage, whether the symptoms were secondary to increasing swelling from, not necessarily even from the bleed, but even post-embolization, you can get swelling as well. And there are multiple factors that may have contributed to her getting some right visual field deficits. So.
I mean, what I would suggest here is, I think, get a post-op MR in this girl, see what the anatomy looks like, and then, you know, Darren and I could take a look at the MR and then determine whether it'd be useful to get another angiogram and/or, you know, either radiation therapy, or I don't know that surgery would be the most wonderful thing here, given its proximity to the language area. But if there was a big retraction around this, and you know, you had if she had an area that was amenable to that, you know, I would put it on the outside possibility, but I think I would be pretty likely to lean with the idea of radiation therapy, but I'd like to see the MR beforehand.
I would agree with that, and I would lean towards repeating the angiogram. It did look like on the post-embolization angiogram there were still intranidal aneurysms, which I would like to target, but I would wait until that clot retracted, because we might be missing a lot of it if we did a study too soon.
Yeah, the clot kind of squishes some of the veins, and you can't always see them as well afterwards, so you want to see it when things have quieted down.
So you guys would be willing to look at those films, of course, if they became available in the future. We had one more case prepared, but given time, I don't think we're going to have time to do that. We can take a few questions and a little discussion. We have received a slew of emails throughout from this printer that has been making some noise here. We're obviously not going to be able to answer them. We apologize to the one family and doctor that for the last patient we can't get to. We will certainly review that, and Maribeth and the rest of us will get back to them. And some of the discussions that we had to curtail a little bit, we'll also discuss these in more detail and get back with our thoughts. Maybe we'll take a couple of these questions. One of them is pretty general, and maybe I'll ask Dr. Folkman to tackle this one. It's a simple question that I'm sure he can handle in 15 seconds or less. Why do vascular malformations happen?
That's a simple question. So many of these vascular malformations are abnormalities of the cells that coat the veins and arteries when they're forming, and normally the inside layer called endothelial cells and the second layer called muscle or pericytes match up very beautifully all through the development of the fetus, the embryo and the fetus. And many of these malformations are mismatches of those, and they're quite different from the tiny hair-like blood vessels that tumors recruit. And so we're having to learn all over again for a different set of abnormal blood vessel growth how to treat these with drugs. So we don't have such good drugs for these as we do for the blood vessels that are recruited by tumors.
He managed to do that. So it's remarkable. So maybe one more question. This writer asks, why are some vascular anomalies treated with sclerotherapy and others treated with surgery? Well, we could extend that. Some of them are treated with drugs and some of them don't need treatment at all. Ahmed Al-Amari, maybe you can comment on which ones are amenable to sclerotherapy, or extend that to, let's say, embolization, and maybe talk about what's the difference between sclerotherapy and embolization.
Well, sclerotherapy is at Children's Hospital Boston. We use it exclusively for low-flow malformations, like venous and lymphatic malformations, while embolization is the term specifically used for treatment of high-flow lesions, arteriovenous malformations, and arteriovenous fistulas. People actually use them interchangeably, embolization and sclerotherapy. And I think most malformations are amenable to either embolization or sclerotherapy. Whether you can achieve a partial response or a complete response, that depends on the anatomy, the type of the malformation, and the technique available to treat that patient. But I don't know what's the percentage of patients who get referred from the Vascular Anomaly Conference to interventional radiology, but I think it's a very high percentage.
I would agree. As a surgeon who spends most of my career operating on vascular malformations, vascular tumors, I would agree that we should look this up. I don't know, but I would say the vast majority of patients that we do a physical intervention for, as opposed to drug therapy, get treated in an interventional radiology suite with embolization or sclerotherapy, and a smaller percentage end up with one of the surgeons here in the operating room. Although I operated on two today, that's that's still a small percentage compared to what is treated. And oftentimes we use combined therapy where we'll have Dr. Podwar, Dr. Alamar, Dr. Chowdhury, who couldn't be here today, do some preoperative treatment, and then Dr. Mullick and Dr. Castor and myself will then resect a portion of the lesion. I think the same is true in the brain with Dr. Smith. We would like to get it to the point where we're not injecting material to try and shrivel things up and cut them off with knives, and we're looking towards the research arena to improve our ability to use medications. But for some of these things, we're quite a while away. I think we're out of time. We'd like to certainly thank all of those who chose to tune in on the internet and those who submitted questions. We will certainly go through this stack of emails and try to address them as best we can going forward. We would also ask that you take a moment to answer the very brief demographic survey that appears on the web, and we would be happy to answer your questions or participate in the evaluation of your family members, your patients, if we can be of assistance in the future. Thank you all.
This has been a live presentation of the Vascular Anomalies Conference from Children's Hospital Boston. OR Live makes it easy for you to learn more. Just click on the Request Information button on your webcast screen and open the door to informed pediatric medical care.